Good morning, everyone. I'm Kimberly Chalia with PHCA. Thank you so much for joining us for today's webinar, the Warm Handoff, presented by Dr. Weisberg. A few quick updates to share before we get started today. This webinar is being recorded and will be made available on the PHCA website in about 2 weeks after today's session. The webinar has been approved for 1 continuing education credit for all attendees. For those who provided a NAB number at registration, credits will be uploaded shortly, and I'll share those certificates with those in attendance. As we begin today, all attendees will be in listen-only mode. Please feel free to submit your questions via the Q&A icon on your screen, and we'll make sure to answer as many of those questions as possible at the end of today's presentation. Now I'll turn it over to Dr. Weisberg.
Good morning, everyone. Thank you so much for tuning in. I'm going to keep my camera on just to introduce myself, and then we'll jump into our material. So my name is Kathleen Weisberg. Very glad to be with you today to talk about this issue. What we're really talking about with the Warm Handoff is those transfers from acute care to long-term care, some sort of post-acute care, and then even downstream after that. So that's our goal for today. Just by way of introduction, I am the National Director of Education with Select Rehabilitation. I've been in this industry for 30 years, which is always still a little shocking to me. And I'm tuning in today from Delaware. I live just north of Rehoboth Beach. And again, very happy to be with you today. So I'm going to go ahead and stop my video and let's jump into our objectives because we are a CE. So the objectives today are to identify the risk areas related to transfers between post-acute settings, to explore some of those negative effects on quality and safety surrounding transitions in care. We'll define what we mean by the warm handoff and how we can utilize that approach. And I actually have some research as well to share with that, and to identify some strategies how you can possibly manage those transitions to mitigate any sort of potential uncertainties. You know, if you think about it, I don't know how long you've been in the industry, I don't know how long you've been doing this, but I think back to when I started, and when we would transfer individuals from the hospital into our settings, we needed just a few key pieces of information, and now we need a lot of information. We have patients who have so many comorbidities, we have faster hospital discharges. It's a really complex process right now, and there's multiple opportunities for failure, and that's actually what we're going to start by talking about. So I should share with you that I'm also a researcher. In addition to my position at Select, I am also a professor at Gannett University, and I also adjunct at Duquesne University in Pittsburgh. So I'm a research kind of geek, so you'll see some statistics and citations in here as well. So you can look at this slide right along with me, failed handoffs. This is that information coming from the hospital to us. And when we look at this meta-analysis that was done in 2020, so this is pandemic time, really. In one study, 41% of the patients had a test pending at the discharge, and those tests were necessary tests, and unfortunately, almost 2/3 of aftercare providers were completely unaware that there was a test pending that they needed to follow up on. In another study, tests were mentioned in the discharge summary 25% of the time. Those tests were only completed about 13% of the time. Tests that are ordered on the day of discharge, and we see that when we get those discharge notes from the hospital, those are 47% of the tests that were never actually reviewed. And then 1/3 of those recommended follow-up tests are never actually obtained by the aftercare provider. So I'll share some personal stories as we go through this today. My father recently, maybe about 2 months ago, he had COVID, and my dad is 80 years old. He became dehydrated, etc. The very, the typical thing that we warn our seniors about. And he ended up going into the ICU with some significant issues, cardiac issues. Well, fast forward, he was discharged, and a week later, he had to go see his physician. He went and did all of his labs, all of his tests, everything that he was supposed to do. I went with him. His physician had not a single solitary test. And his physician, not only that, is in the same network where my father had his tests done and didn't have them. And so thankfully I was there to say, no, these were done, you have them, please go pull them. And I had a copy of them myself. But what if we're not savvy enough to do that? What if we don't know those tests are out there? And I love when I teach this live, because I get to see everybody's heads, nod up and down. I know what you're getting from the hospitals, the discharge summaries, or the giant stack of papers that you get from your hospitals that no one can possibly weed through. And there are gaps and there are holes in that information. And that's a prime example. So also from this same meta-analysis, 12 to 34% of those discharge summaries are not even getting to the post-acute providers in time. Or if they are getting there in time, again, there's a lot of holes, there's a lot of discrepancies. The reality is that if we don't have that communication, and I'm not going to read this slide at you, but we don't have good information, that impacts not only us, but there's financial penalties, et cetera, for us, but it's traumatic for the patient, because then we end up with a hospital readmission. And that's really what we're talking about today, is how do we prevent those hospital readmissions? It's traumatic for the patient, and it leads to poor quality outcomes. Now, there's obviously a significance to long-term care, and again, I'm not going to read this at you. You're very much aware of that 30-day all-cause readmission measure, which of course has been suppressed because of COVID, but it's not going to be suppressed forever. It will come back, and it is something that we need to really strongly look at because of this. In 2018, so again, this is pre-pandemic, 73% of SNFs, 83% of hospitals were actually penalized because of those readmissions. And again, not only is that traumatic for the patient, it's costing upwards to $20 billion. And aside from that, what is it doing for you? I mean, if a patient knows, or a resident knows, oh gosh, if I go to Happy Day Manor, gosh, I hear that, gosh, they don't take good care of people and they go back to the hospital. That's your reputation. Those are referrals from those hospitals. So it behooves us obviously to address this and focus on this. One last slide about this, and I don't necessarily expect you to see this, but this is the IMPACT Act requires reporting of standardized patient assessment data. And this comes directly from CMS, their meaningful measures. The very first one is promoting effective communication and coordination of care. And again, that's really what we're talking about here, promoting that coordination. And again, if you didn't get enough background, there's also a transfer of health information measure in process right now. It's something that is under development, looking at how health information is transferred to the patient, to the provider, et cetera. So how are we accessing that, exchanging it, so it's a seamless transition? So really a lot of good reasons to focus on transfers in care and particularly reducing hospital readmissions. So the question comes up, are we doing enough? And if I asked all of you, are you preparing people for discharge? You would say, absolutely yes. Have you done everything that you're supposed to do? You would say, yes, no doubt. We're dotting the I's, we're crossing the T's. But the reality is our patients don't agree with us. This study, and I don't have the citation up here, was published in the Journal of Hospital Medicine just last year, actually. The perspective of patients, only 28% felt that they were ready for discharge. They didn't feel like they could control their pain. They weren't sure if they could do their ADL or their IADL, their instrumental ADL, so transportation, taking their meds, those types of things. People said, yeah, I got paperwork, 65%, but When asked, less than only about 22% could identify critical information from that paperwork. And the reality then became that they had rehospitalizations as a result of it. They didn't remember what was in that discharge paperwork. Adding to that, 85% report having a primary, but only 56% actually contact that person before they present at the ER. And we all know that if I present at the ER and I have an issue, most times the hospital doesn't have much of a choice but to admit that patient. Again, I'm going to go back to my father's story here just to share with you. And he was in a really, really good hospital. My family is from Pittsburgh, I should share. And when the day of discharge from the hospital, I timed it. I think the nurse spent with our family, my father, my mother, me, approximately 6 minutes reviewing the discharge paperwork. And this was after, again, a serious cardiac event. They had discharged all of his cardiac meds. So 6 minutes after spending an entire week in the hospital. And so then they come to us or they go home, and again, we go back to it. There are holes. So we do need to do a better job here, and we'll talk a little bit more about discharge planning as we go along. Okay, so I'm going to skip over this slide. I'm just going to jump right into our steps that we follow. There are 3 steps that we're going to be following here. The first step is, and I'm going to tell you, as I read through some of this stuff, we talk about this, I realize how basic this sounds, but the reality is we're not always doing some of these things. So this first step is just making sure that we, at the skilled nursing facility, assisted living, even if it's independent living, whatever the post-acute setting is, home care, whatever, that we are ready and capable to care for that person. So that involves confirming what that person needs to come into our community and resolving any questions, making sure that it's a good fit. So how do we go about doing that? And again, I'm not going to read all of this to you. You have this in your handouts, but I think the one thing that I would recommend here, and the literature would recommend, is to have specific transfer criteria. And what we mean by that is, you know, identifying, oh, if they are going to come here, it has to be during this time frame. And, you know, they have to be at this status. These steps need to have been, you know, taken care of, whatever that happens to be. So making sure that everyone knows what that transfer criteria, what those are, and that if they change, we update them so that, again, we are pulling in individuals that we can actually care for, quite frankly. Another thing to do here is to just get that contact information for the consulting physician, whether that's the hospital, the primary, whoever that happens to be, because we'll talk about this as we go on, that if there's a question, if there's an issue, if there's a discrepancy, we want to know who we call immediately to get it resolved. Who do we call to ask the question? And maybe it's not the physician. Maybe it's a nurse practitioner, or maybe it's a nurse at the hospital, somebody like that. We're obviously going to review the clinical and the functional status. And, you know, I think back, and again, if you've been doing this for a while, think back to what we used to do. We always sent someone out to the hospital to look at that person, lay eyes on them, come back and report to us. I will tell you, if that is at all possible, then is, the literature would say the same, that is going to be your best bet to really get the functional, the clinical status of an individual coming into your community. The other option is obviously having somebody get that information and then present it maybe at your stand-up meeting or your Medicare meeting, wherever that happens to be. The important piece here is that we want to make sure that whoever is on that paper or whoever we saw in the hospital is actually the person who comes to us. And I'm going to give you a real example that a client that we were working with, Select was working with not all that long ago. And this again sounds so basic. Person, they did all their due diligence, had all the information, discussed the patient at stand up, what have you. The person came into the community requiring dialysis. No one ever told them. And they were scrambling. And of course, they set up the dialysis services. It happened. but they were scrambling. What if they could not have done that? And that's kind of an extreme example, but for that to have happened, something is broken, obviously, in that system. And I think the other piece, and I know I'm telling you something you already know, how many times do you get that information on that patient maybe on a Tuesday, and they're coming to you on Thursday or Friday, and they're a totally different person on Thursday or Friday than what they were on Tuesday, and they've changed. So we just want to make sure that we have those systems in place. One tool that I will tell you I absolutely love, and I can't take credit for this, I use a lot of and this is not a commercial for them by any stretch, but I use a lot of Interact tools, and maybe you guys do as well. They have something called a nursing facility capabilities list, and I love this, It goes through all these different things, and again, I'm not going to read everything at you, but diagnostic testing, for example. Can you do stat EKGs? What about x-rays? What about lab work or blood work? What about, oxygen? Can we provide oxygen? What about ventilators or trachs? What do we do as it relates to wound care? Can we provide that? Can we do IVs, et cetera, et cetera? I love this list for a couple of reasons. Number one, asking the question, can you care for that individual? So somebody's coming to you with a stage 4 sacral wound. You don't have the services for that. We should probably not take that admission. It's knowing who you can care for, because if you bring somebody in that you're not equipped to care for, you're not doing that patient any service, you're not doing yourself a service, and very likely that person's going to go back out to the hospital. So I think that's the first thing. Second thing is a marketing opportunity, I think, to some degree, so that, we can provide this list maybe to the hospital discharge planners to say, hey, we do these types of pulmonary programs, we do these types of wound care programs, et cetera. We have an edema, lymphedema clinic, whatever, that they can send those referrals directly to you. You could also market your niche if that is something that you have. And I think thirdfold, is we can use this for education and training. So that we look at this list and say, yes, we can do all of these things, but we're not so good here. Maybe that's something where we can beef up our skills and our services that we provide, so that we can provide more to more people. So again, I like the capabilities list. The next thing that we're going to be looking at, again, is making sure that we have that safety during the transfer. So again, not just relying on that paper. I can't say it enough, picking up the phone. Yeah, so kind of a combination of systems where you get that information from the hospital on paper, but then we either have a structured handoff tool, we have a script, we have something where we pick up the phone and just verify that what is on paper is exactly who that person is. We're talking, and I use the SBAR here, and we'll talk about SBAR, the situation, background, assessment, recommendation, just to make sure that we have all of that information. So as we're talking about these transfers, again, this is a form that Interact has put together, and maybe you put together something on your own. I have a couple of tools that I'm going to show you as we go. But getting that information, so I'll talk about the hospital to us in a second, but if we want information from them, we've got to make sure that we're giving information back. If we do send someone out to them, that we're giving all that information: diet, swallowing status, allergies, fall risk, pressure ulcers, restraints, assistive device, et cetera, all of those things that we know about someone, and of course, the primary contact back at the skilled nursing facility if they have questions. And then we want the same thing from them, right? We want, the physician, their vital signs, their treatments. Do they have a PICC line? Do they have a pacemaker? What's their most recent glucose rating, their skin assessment, et cetera, et cetera. Getting all of that information so that we can assist with that assignment, we can make sure that we can care for this person, and again, knowing who to contact if we have questions. The goal here is to avoid the gap. We've already said this. Resolve any concerns that we have about that person, or if we can't resolve those concerns, maybe we defer the transfer completely or we defer it for a certain amount of time if the hospital would allow that. We want to make sure that whatever we do, we're not placing the resident at risk for any sort of complications. Also making sure, can pharmacy get the medication? Can we get the equipment? Again, another story, and I don't remember where this was off the top of my head. Somebody came into the community, and I don't know if it was just overlooked, if it wasn't communicated, I don't know, but they needed a bariatric commode, they needed a bariatric wheelchair, etc., and that wasn't available. And that person struggled to get out of bed, etc., for at least the first day of their transfer. And of course, we don't want to set up those sorts of situations. So what are the failures? I don't think I need to read this to you. You realize what this is. Incomplete information. We didn't truly assess the resident's need. It all goes back to communication, making sure that we are communicating with our hospital partners, and I haven't said this yet, but also our downstream partners. So when we discharge someone to home care, or they're going, home and they're going to receive outpatient or something, that we are communicating the same information. The more we communicate, the better off that transfer is going to be. Ultimately, what CMS would like to see, what I think our patients would like to see, is that there is continuity between settings, so that if I spent 5 days in the hospital, when I come to skilled nursing, I pick up on day 6. It's not day 1 all over again, so that we have that continuity. Okay, second step, we are going to reconcile the treatment plan. So we're shifting gears here from the transfer into our community now to treatment. We're reevaluating and we are reconciling that treatment plan. The biggest piece here, I'm going to hit on 2 things, and we'll talk about medications in a second. It's strongly encouraged to involve the resident, the family, the caregivers, anybody in gathering information. In a recent study, 1 out of every 5 hospitalized patients had some sort of adverse event that the family had information about and could have shared. Oftentimes, the family can fill in some of those gaps. They can fill in that white space. They're there in the hospital. They're paying attention. They're getting that information. So we definitely want to ask them that information. We talked about the process for verbal communication. That is, in fact, that warm handoff, talking to a person, much like we would do within our own organization. You're changing shifts and you have shift change meeting. Hey, so-and-so did this, so-and-so did that. It's the same kind of thing, getting that direct verbal communication. And then there's medication reconciliation. And again, I know you all are doing this. I would just say this, make sure that whoever is doing your med rec is doing a very, very thorough job at it. I tell stories. I don't know where I was. I do. I won't share for protect the innocent, shall we say. That I asked the question, who's doing your med rec? And they said, pharmacy's doing that for us. And I think that's typically the case. So, some combination between pharmacy and nursing. And when I asked pharmacy, all of the things that they looked at, they weren't looking at the same things that we were looking at. So it behooves us to just have our hands in that, because the number 1 reason that people go back to the hospital is medications. They either didn't get their medications because they can't, they have a transportation issue, or somebody didn't deliver them, what have you. They don't know how to take them. They don't know how to set up their pill box, what have you. And again, I'll just give you my dad's information. I don't know that he would like me violating HIPAA so much. But that aside, when he came out of the hospital, I had come back to Delaware, and so we were setting up his pill box via Zoom one day, and he had this medication, and I swear it was a 4 or 5 syllable word. And I'd like to think I'm kind of smart. I had no idea what this medication was. I looked it up finally. It was folic acid. I'm like, oh, okay, that's easy. And I called his physician. I'm like, can we just get this over the counter? Does he have to have a script? And of course, they could do it over the counter. But here was a simple thing. again, it could have gone a very, very different direction. So that's where you need to seek that clarification, get those resolutions. How often does it happen that, you know, you send somebody out on a list of meds and they come home or they come back to you with something totally different, or they've changed the dosage, they've changed the route, they've changed, you know, something else on it, or there are parameters. We need to have a lab, there's a stop or a change, etc. A lot of clarification needs to happen here, that, you know, just understanding, why is this person on this medication? Did we really look at drug interactions, etc.? It's a pretty involved thing. Again, I can't take credit for this. This is another Interact tool, but I love it. Hospital recommendations. So there's the medications. What kind of clarification do I need? What's the resolution? Things that the person had prior to the hospitalization that I need to clarify, and the same thing. So really, again, looking into that. Along those lines, and we've already talked about this, but having that consultation, so knowing what to report, when to report it, and to whom do I report it? Because again, if you don't know who to call, what to do, how to get information, you may have no other option than to send somebody out to the emergency room. And of course, you don't want to do that if it's an unnecessary, now of course it's a necessary transfer, you do what you need to do, but we're really talking about those things possibly that can be managed in-house. So another tool, and I don't know if anybody uses this, I suspect a lot of you probably do, it's the stop and watch. And I tell people this, and I have to say I love it. Years ago, when Pennsylvania Healthcare was still having their meetings at Seven Springs, there was on the back of somebody on the badges that were out in the front, stop and watch was on the back of some group's badges. And I don't know if anybody remembers that. But I saw that, and I'll tell you, I fell in love with it, and it's something that I've recommended to people for a long time. I love this. It seems different than usual. Talks or communicates differently. They ate less, they drank less. There's a weight change. They're tired, they're weak, they need help, what have you. What I love about this is that every single person in your facility, therapy, activities, nursing, housekeeping, maintenance, your van driver, everyone can use this and communicate when things just don't seem right. And the whole point of this is, number one, communication. How many times have you seen something and you're like, oh, I need to make sure I tell the charge nurse, blah, 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 and your day just gets ahead of you and you forget to do it, or nurse to nurse, we don't get there, or I want to remember to chart this, and again, your day gets ahead of you and you just kind of forget about it. So it is a nice tool for communication. The other piece, and this is the important part, is that we can start to recognize when there are issues, when something just doesn't seem right, and we can try to get to the bottom of what that issue is before it is magnified, before it's so full-blown that this person does need a hospitalization. So it's keeping our eyes and ears on that person. And again, I love the idea of putting this on the back of your badge, or I know a number of folks have included it in their EMR, different things like that to make sure it's happening. Now, along those lines, a couple other tools that are out there, and again, I can't take credit for these, but I love them. And you can certainly, again, develop something on your own that's similar to this. This is a change in condition card. I love this. It helps our nurses to determine, do I report these symptoms now? Do I wait? What do I do about this? So this is one for vital signs. This is what you report immediately to the physician or possibly send to the ER. This is what you can monitor and then maybe report the next day, and maybe this is what you can do about it. So again, this is not the end all be all, but it does help to kind of figure out what can we manage and what do we need to address immediately. Along those lines are these care paths, and again, you can develop these on your own as well. This one happens to be for UTI, but it asks the questions. Okay, here's symptoms. Let's take their vital signs. Did you see any of these things? Yes. Call that physician immediately. No? Well, did you do this? Did you do this? Did you do this? So it guides us to some of that clinical decision making, some of that clinical reasoning Can we handle this in-house, or do we need to contact someone and send them out? And again, don't misunderstand me. I'm not saying we don't send folks out. Of course we do, but we want to make sure that it's a necessary thing instead of something that possibly we could have handled. Now, one of the things, and again, this is an interesting study that came out of Missouri, where they were using advanced practice registered nurses, and they brought those folks on site per nursing home, one person per nursing home. They found that having that person there, that early recognition, they could quickly intervene, they could provide the treatment, order the labs, change the meds, do whatever was necessary, maybe interface with the physician, decrease their hospitalizations by 33%, and a savings of a little over $1,300 per person. This is my time to kind of plug nurse practitioners. I don't know if you use those individuals in your communities, but there's really nothing but upside. They directly bill, their services, and they are there for you to help you to identify some of these issues. They're not there to be a foe, they're there to be a friend and certainly help you through some of this, especially when it's difficult sometimes to get a hold of your attending physicians, or your attending physicians, are wearing multiple hats and just don't really have the time to deep dive some of these things like an NP might. So definitely something to consider. So we're talking about the physician, or maybe it is an NP or somebody else. One of the big things to prevent unnecessary hospital readmissions, have all of your information. And I know we're doing this, but evaluate that person, check their vital signs, and do your SBAR. What's made it better? What's made the situation worse? Other things that may have contributed to this. What's their background, their vital signs? What's their function, their mental status, their pain, their intake, their output, labs, whatever? What's their assessment, if they're an RN, or their appearance, if they are an LPN? And then what's your request or your recommendation? Maybe it's a visit, maybe it's monitoring those vital signs, doing some lab work, IV fluids, whatever. What's important here is that if we are calling a physician and we just say, yeah, there's been a change, and we don't have all of this information to share, what choice does that physician have other than to send the person out, to say, please transfer them to the ER? If we have a lot of information that we can share, particularly when, a physician has gone on vacation and there's an attending who's not familiar, maybe it's the weekend, maybe it's the evening, something like that. The more information that we can provide, the better the decision-making ability of the physician or somebody else is going to be. So for step 2, our typical failures are just really, I think we've kind of talked about these, just the med errors. We didn't get the medications, we're not getting the lab results, and we're not sharing as much information as we should. So step 3, I've already mentioned this. Sorry, taking a sip of coffee there. This is, again, engaging the resident and the family. We already talked a little bit about that, but the failure here oftentimes is that there's different expectations. And of course, that. We see something, we have different goals and thoughts sometimes, particularly related to discharge planning, than sometimes what the resident and the family have. Sometimes we don't include the resident and family. Sometimes we're not doing really good teach back, return demonstration, getting somebody ready for discharge. And we'll talk more about that in just a second. So our lessons for track and field, I don't know if anybody is a runner. I haven't run track for a long time. I did cross country for years, but you're only as good as your handoff. You're only as good as the baton that you pass. You're only as good as the baton that you take. And each person has a key role there. So with that in mind, and I'm going to go through this a little bit quickly. There's a bunch of slides, but I'm going to talk about it and go through the slides pretty quickly. Cross-continuum partnerships. What is that? What are they? This is where we take individual, so it's a facility, it's a hospital, it's an assisted living, whatever, we all come together and we visit. We have cross-setting site visits to provide each other with an opportunity to really see what happens in that setting. I mentioned early on about having that continuity of care between the different settings. This is how you get this. When you come together, you can figure out, where are our gaps? Where are we falling short? This is where you can talk to that hospital partner and say, you know what, and you can use a case study to do it. When you transferred so-and-so, this is what happened. This worked really, really well. We fell short on this. How can we tighten that up? What systems can we put in place? And we really work together with that cooperation. When you are visiting, and if you've ever seen this happen, I've worked with a couple of communities where they did this, and it was really eye-opening. In fact, I have some of their feedback on another slide. The visits are completely transparent. This is not an open house where you're doing, what's the term, the dog and pony show. This is where you are truly showing a day in the life. You're showing your ugly as well as your pretty. You're telling your story, you're sharing your outcomes, you're giving really good information and facility-specific processes. Again, they need to see, the hospitals need to understand what you're doing as much as you need to understand what they are doing. So again, we come together to identify areas for improvement. We have room to improve as much as our hospital partners do. And maybe it's as well, we are meeting with somebody downstream to make sure that we are doing that transition appropriately. So it's very transparent, open discussion, and it works. It works. The conversations change when everyone is at, and this is a proverbial table. People don't sit around the table. They're actually out there hands-on. It feels good to have us all in the room with the patient at the center of our work. Staff at the different sites of care can pick up the phone where they didn't before. We make more referrals to skilled nursing facility X as a result of the improved communication. And that's ultimately what you want. You want that collaboration, communication. You want referrals as much as you also want to make sure that you are preventing hospital readmissions, and they want that same thing. So this is something that really works, because what you're doing is just this. You're co-designing, you're standardizing that transfer information. So that list I gave you before, maybe you use that, or maybe you develop something in tandem with your hospital partners to say, this is what I need from you. And they say back to us, well, this is what we need from you. And we standardize whatever that form is. Maybe it's education material. If we know somebody is having a hip replacement, they are giving the similar information for education that we would be giving. So again, it's working, going back to enhancing that communication, that meaningful measure that CMS is looking for, and that transfer of information. If you can, and I don't know if this is always good or bad, can we use the same EMR? Absolutely. I think a lot of you probably do. You share medical records or EMR or whatever with your partners. I don't know how effective that is sometimes. And again, I don't know what you guys are experiencing, but sometimes those electronic medical records are massive coming from the hospital. I'll share a quick story. I was an expert witness for someone not all that long ago, and I was reviewing the medical records. Person was in the hospital, I don't know, maybe 7 days, give or take, and there were about 2,200 pages of medical record information. And I weeded through it all because I was an expert witness. I had no choice. You don't have time or energy to do that. So yeah, you're getting all of that data, you're getting all of that information, but is it actually useful if you can't read it all, or if you can't find what you need? So that's again where maybe it's some sort of other tool, some other communication strategy that you utilize to get that information. Which brings in the warm handoff. So if you've ever worked in a hospital, this is really common in the hospitals. You know, I'm in ICU, then I go to step down, then I go to a regular bed. We hand off. We say, this is what this person's doing. This is how they're functioning. These are their meds, blah, 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 all that stuff. one of the issues here, one of the failures, if you will, is that it says not all the SNFs are the same. I'm so sorry. It should say same. And that's funny. I'm so sorry. So not every SNF is the same. And our hospitals sometimes don't realize that. They just lump us all together. Staffing, supervision, capabilities, patient set, what have you. So this is where better reports, and again, that verbal connection is a must. So this study was actually done in 2019, and it is the Warm Handoff study. So they took individuals in this hospital. There were eligible discharges. There were a little over 2,400 who were eligible. A little over 1,000 included what they called the Warm Handoff, where somebody from the hospital called the SNF, somebody from the SNF contacted the hospital, and they had that verbal dialogue. The reports, the outcomes, better care coordination, better communication, better functional outcomes, fewer hospital readmissions. The drawback, people didn't really understand, like, why am I doing this now all of a sudden? Why is this necessary? How can I do this efficiently? I don't have the time for this. And yeah, it takes time. But if you have a process in place, if you have some sort of format, and actually I'm going to show you one on the next slide, some sort of checklist format, whatever it happens to be, it shouldn't take an exorbitant amount of time. It should take mere minutes to get that information. So this is something I found out in the public domain. I don't even know where this came from, but it's very similar to that transfer document that we talked about, that I can pick up the phone and ask the question, what were the vital signs in the last hour? What are their preferences? Are they on oxygen? Do they have wounds? Do they have diabetes? Blah, 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 blah. Super quick and simple, the nitty-gritty that I need in the Warm Handoff to make this a successful transfer. And again, I guess you could do this via technology as well, but the studies have shown that the more we can do this verbally, the better off we are. So I've been talking quite a bit about hospitals. So I want to talk a little bit now about downstream partners. Now it says here early engagement with post-acute providers. I realize that you all are post-acute providers, but part of this is thinking about, where do they go when they leave us and what happens? So was the durable medical equipment ordered? I was in a community in New York not all that long ago, and somebody was being discharged that day. And I was just doing my checks, my compliance kind of thing. And I said, well, what DME did you recommend? Oh, wheelchair walker, a tub bench, whatever it happened to be. Was it ordered? Yep. I gave the requisition to social service. They ordered it. So I asked the question, did you order this? Yeah, I ordered it. The patient went home. It wasn't until a couple days later that we found out nothing was delivered. So we checked our box, but did we follow up to make sure that it was there? And I wonder to myself sometimes, how often is that kind of stuff happening? We ordered home care, we ordered outpatient. Does the person know where to go? Do they know what time? Do they have transportation to get there? Follow-up appointments are the same thing. Yeah, we made all of these. But does that, again, I'm thinking about my dad. He had to do a follow-up with some physician, and he's like, Kathleen, I don't know where this is. And so we had to Google it on the map and then, get him directions, et cetera, to make sure that he could get there. I mentioned medications is the number one reason why people go back to the hospital. The number two reason is that quote unquote social side of the discharge. They can't get to their appointments. They can't get their medications delivered. They go home to an empty refrigerator and have no way to get groceries. So some of that kind of stuff. So again, we've ordered the meds. Does that person actually have them? Can they get to them? And I'll talk about that on another slide. So I'm just going to go past that. So this is, again, another tool. This is one that we developed at Select, and I should share that anything that you see in this presentation, any of these resources or tools, if you want anything, don't hesitate to email me. I'm happy to send them. But this is a Warm Handoff, another example of something for transitions. This is their activity. These are their instructions. This is the type of DME they're going to need. Again, just a quick checklist to make sure that we are communicating that. Okay, so we're going to talk a little bit about outcomes and quality improvement. I certainly hope this is exactly what you look like when you are in your quality assurance performance improvement meetings and you're tracking your outcomes. As we think about outcomes, what we want to be thinking about is how are we communicating our success to our patients, our families, our hospitals, our physicians. We know 5 stars out there, etc. But are we shouting from the rooftops all of the good things that we are doing and how we are helping individuals to meet their goals, to go home, to be successful, to be safe? We certainly want to talk about that. Because again, when I think about outcomes and such, when that transfer process is a failure, when it is less than adequate, your reputation is at risk. Your brand is at risk. People are going to be talking about you. We know that. Legal issues may come up. There might be a financial risk. Somebody may sue you. You could have a compliance or an ethics investigation, a fraud investigation, etc. And I don't need to tell you what you already know. Our industry is the most heavily regulated industry there is, and it's only getting worse. Let's be honest. And we just want to make sure that we are doing all of the right stuff, that we have an internal process, a robust process to self-monitor, to assess, to audit our compliance. And that's where this acute care transfer log comes in. And actually, I'm going to pull it up to the next slide so you can see an example. This is your tracking mechanism to look at, okay, who went to the hospital, when did they go, what was their status, what was the time, what was the outcome, etc. So you can use this to analyze for trends. And again, this is your quality assurance performance improvement. You can start to summarize your findings. So what are your resident characteristics? Well, was it a specific age? Maybe most were over the age of 85. Was it something related to their length of stay prior to the hospital transfer? Were there risk factors? And we'll talk about that in just a second. Specific diagnoses. Were there changes in condition? What were the actions prior to the transfer? Were there tools? What tools did we use to manage this condition? Were there tools that could have been used, but we didn't use them? What type of medical evaluation was done prior to the transfer? Did we really do our SBAR? And then asking, were there some other reason here? And then what other contributing factors? Was it a specific day of the week? So it's always on Sunday. Specific time of the day, always in the evening? Is it always a specific physician? Or maybe it's a family member or something. So what kind of trends are we starting to see? And then we can ask the question, could this have been avoided? Were there early warning signs? Was there something in stop and watch that we saw, but we didn't address? We didn't communicate it. We didn't do anything about it. Was there a precaution? Could we have actually provided the care instead of sending the person out? So going back to some of those decision trees that we have. Again, the goal here is just to think about those unnecessary transfers and what could we have done about it. Now, I mentioned screening tools. There are 2 different types of screening tools, and I will share with you. I'm going to review 3 here. These are available in the public domain. The first type of screening tool will give you a risk score, actually risk identifiers we'll talk about first, and then risk score second. So this first one is called the 8P, and oh gosh, you can't see that, so I'll just go back here. So the 8P is an actual screening tool. These are the P's that it's looking at. So problems with medications, so polypharmacy, anything more than 10 routine meds that the person might be taking. The second P is psychological. So if the individual has maybe depression or some sort of depressive diagnosis, and this is probably a good time just to mention the PHQ-9 or the PHQ-2-9, whatever you happen to be using. So important outside of the scope of our conversation here, but we do that, of course, on admission. We do that when our MDSs are due. But it's something that we really want to keep our thumb on, keep our finger on that pulse, for the fact that when somebody transitions from hospital to skilled to home care, whatever, that the stress and the trauma of that transition can extend easily 8 months after the transition, and we can see risk of suicide increase quite a bit. So anyway, outside of the scope of this, but just my public service announcement to just really be paying attention, be watching for those signs of depression. The third P is the principal diagnosis. So cancer, stroke, diabetes, COPD, heart failure, those sorts of things. The next P is physical limitations, deconditioning, frailty, malnutrition, other limitations with function. Poor health literacy, so that's that inability to do a teach back. Patient support, so are they socially isolated? Do they have family support? Do they have, options out in the community, etc.? Prior hospitalization in the last 6 months. And then finally, palliative care. Would you be surprised, and the way the question is asked on the tool is, would you be surprised if this patient died in the next year? What's neat, and I know you can't see this, and I apologize, but what's neat about this particular tool, the 8P, is that when you go through each of those issues, there are risk-specific interventions that are offered, and then there's a place for staff to actually sign off that these were completed, they were educated. So this is a nice tool to assess, do I really need to pay maybe a little more attention to this person and their possibility of being transferred back out? And if I do, what can I do maybe to mitigate that risk? The second tool that again is available in the public domain is the LACE index scoring tool. And this actually looks at 4 things. You can see what LACE stands for: the length of stay, the acuity of admission, comorbidities, and the ER departments. This is, you can actually see this one, I think. Anything that is a score higher than 10 is a high risk for rehospitalization. So this is one that the hospitals cannot do, or maybe they can, but it can't be done until the very end of the stay because you need that length of stay. The acuity of the admission, those comorbidities, look down through that list. MI, CVA, tumors, dementia, etc. A lot of those are the exact same things that we are tracking for our NTAs for PDPM. And then ER visits. So you total it up, again, anything greater than 10, that's somebody that we want on our watch list for possible hospital readmission. This final tool, not available in the public domain. This is one that you have to pay for, but it's the hospital score. And in that second bullet, you can see what hospital stands for: hemoglobin, oncology, sodium, et cetera, et cetera. And this is one that it's been in use for quite some time. There are about 120,000 patient discharges in this particular, and it's an online validated algorithm, and it's pretty accurate as it measures. Again, it's something you'd have to pay for. It's completely online, but it is validated. The other 2 are things that are, again, available in the public domain, free of charge to download. So I mentioned, early on, talking about successful discharge and, are we doing everything that we need to do? And I hope that answer is yes. I think sometimes, though, we do, in fact, miss the boat. Again, upstream, downstream, I don't think it matters. Let's have some protocols in place. And this is a protocol that we developed as Select. And I don't even know what this is. It might be cardiac, it might be pulmonary, I'm not entirely sure. But it's not a pathway where you say on day 1 you do this, on day 2 you do that. It's more of a checklist to say, did you do all of these things? Have you addressed all of these things? Because sometimes we think we did, and in some cases we didn't. Like, look at the education here. Did we educate on risk factors, medication use, breathing exercises, the home program? Did we do a home assessment, etc.? So again, dotting those I's, crossing those T's. Another thing that we need to look at in preparing for successful discharge, I'm going to spend a minute or 2 on this particular slide, is again, just really making sure that person can do what they need to do and be safe with it when they go home. Remember back to that early study where people said, no, I don't feel ready. I'm not sure about my ADL status. I'm not sure about my meds, etc. So I'll tell another story, a group in New York that I was doing a site visit, and I cover the whole country for Select, but this was a while ago. I was in New York, and I was blown away. I thought this was one of the best things I had ever seen, and I still talk about it. In their physical therapy gym, individuals would come in for therapy, And day 1, day 2, they were doing exercise, they were doing whatever they were doing. By about day 3 of the stay, the therapist had taught that patient their home exercise program. Here are the exercises that you need to do that you're probably going to be taking home. I'm going to teach them to you. You're going to do return demonstration, however long that took. And then moving forward, you're just going to do those. You can do those in your room. You can come here to do them, whatever you want to do. But you're going to start your home program early. And we're going to focus on the other stuff in therapy, walking and transfers and all of that kind of stuff. It was a process that by doing that, when that person went home, they were 100% compliant. They knew exactly what they were doing and how to do it. So that was a really nice teach back type of thing to do. I think we need to do the same thing with ADL programs. You know, how often do we see, you know, whether it's the OT, the CNA, whoever, sometimes we just do the ADL instead of really giving that person the opportunity to be independent, because doing it is faster. We've got to make sure that we allow that person to do that. Medication management, gosh, that's a tough one, because I do realize that in a lot of our settings, individuals cannot be responsible for their own medications for a lot of different reasons. But maybe there's another way around that. You think about how we do med training sometimes now. It's happening, you know, maybe the day of discharge, the day before, even 2 days before. Why aren't we starting that significantly earlier? We always say, yeah, we talk about discharge as soon as they walk in the door, but do we really? So even if they can't be responsible for their own medications, maybe we can do a sample pill box with, you know, Tic Tacs or something like that. I was just in Nashville a couple weeks ago for an Inspire conference. I met with folks from a company, Mind VR, they're a VR company. Anyway, they were telling me about this thing that they had developed, and I was blown away when I hear some of this stuff, that they're developing a med management module where in the virtual reality space, the patient can pull medications off of a shelf, they can open up the bottles, put the pills in a pill box according to a very specific schedule. So maybe we can use VR. And you hear, it was another company I met with, they were doing like a grocery shopping thing where the person would have to pull things off the shelf and then come back and make a sandwich or something in a virtual world. So maybe if we can't do things live, are there opportunities for us to do that maybe in a virtual world or to do something else? Okay, we already talked about engaging the patient, so I'm not going to go back over that. And here's another early discharge planning tool. Again, the current assistance, here's the goal, here are the instructions, here's everything that you're going to need to know. Just a couple other things. I think I just have 2 slides left, just on preventing readmissions. You know, one of the questions is, how are you going to continue to work with this client after discharge? Their readmission 30 days after they leave you is still your readmission. So what are you going to do? And can we have, we do have a lot of, we talk about client, advocates or something like that, health navigators. Can we do something along the line of that? Can we use technology? I just met with somebody the other day and they were telling me about this technology. It's app-based and it's on the person's phone. Their phone is in their pocket or whatever, and they track real time when that person gets up and walks around, etc. If that person doesn't get up for a certain amount of time, they initiate a phone call to the person. Are you okay? Can we help you? There's some really cool stuff out there. This is maybe where you take advantage of remote therapeutic monitoring codes or something, again, to make sure that folks are doing what they need to do. And then addressing that social side of the discharge. I mentioned this already. Are the medications there, the DME, etc. And again, I don't know how this group in New York that I'm telling you about, I don't know how they got around this. I'm not sure what exactly they did, but they initiated. So if they called someone and they said, oh, I don't have my medications, or I have no way of getting to my follow-up appointment or what have you, they arranged for transportation. Now, whether it was the facility van or they had some arrangement locally, I don't know how they did it. And again, I'm not saying we have to go to that end, but is there somebody addressing that social side of the discharge? Or are we just relying on home care or the family, and maybe the family's gone home or what have you? So do we have something in place there? And then I think the other question to ask is who is placing follow-up phone calls? Again, I'll speak to my father. He left the hospital and I happened to be there. He got, I'm not exaggerating, he got 12 phone calls one day. 12. That's insane. And one was, did you like your food? Was the room clean? It was just all these different questions. And here's my poor father trying to tease out what's important, what's not important. And I don't care who this person is, but maybe it's just one person who coordinates and places those phone calls to try and really figure out, is this a successful discharge? Did we do everything for that transition, or is there something that maybe is amiss that we need to address to again keep this person safe and keep them at home? Okay, so with that, I am going to turn my camera back on, and I'm just going to go through my references here very quickly. And because I am a researcher, there they all are. And I will very quickly just come back to the beginning so that you have my contact information. Like I said, if there's anything in there that you want to see again, you want copies of, don't hesitate to ask. And I will, if you have questions, feel free to ask those and I'll certainly address them. But otherwise, I'll turn it back over to you.
Thanks so much. I'm looking at the Q&A icon at the bottom of everyone's screen, and I'm not seeing any questions coming through, so I just want to give everyone a moment. If you do have a question, to submit those now. We're happy to answer those. If you do not feel comfortable submitting a question on this platform, please feel free to reach out to myself or Kathleen. Kathleen's information is on the screen in front of you. Not seeing anything else coming through, and that's a-okay. Like I said at the beginning of today's session, I will be sending through everyone's credit information within the next 2 weeks. And thank you so much, Kathleen, for presenting today.
Thank you so much for having me. I hope that everything we talked about, you're just checking it off and saying, yep, I'm doing all that stuff. And maybe you got a couple nuggets in there and at least some things to go back and review and make sure that we're doing a good job. So again, thank you for everybody who tuned in today, and thanks to Pennsylvania Healthcare for hosting me. I appreciate it.
Thanks so much, everyone. Have a great day.
Bye.
Bye.